Very good. We're off to a good start already. So this is HIT211 Week 6 live lecture. We're getting very, very close to the end of the course. And we are going to cover the chapters under the Week 6 module. Okay? And that is going to include, here's our handy agenda. We got the endocrine and nervous system, your eyes and ears, and your radiology and those are in your text. That would be chapters 25, 26, and 27, I believe, if I'm not mistaken. Okay, so we're moving right along, and we're going to handle this the same way we did last week. Everyone seemed to thoroughly enjoy that, so we're going to continue with that structure. Make sure if you don't have it, run and get your coding manual or some method of coding, or getting your codes, assigning your codes, and also just to remind you, the PowerPoint. Oh, my mind. Is in the file box. Okay, so you can download that and keep that for your records. Use it to practice with, or something like that. Okay. All right, so let's get going. And just jump right on in there. Let's move to the first. Okay, this is going to be our case 1. So we're starting. This is going to be our endocrine and nervous system chapter. That's where we're going to start. And I'm trying to flip over. In just a second. So once we cover the coding, then we're going to do a quick little overview of the cases for the week, and then we'll be done for the night. All right, so endocrine system. So of course with that, we're looking at, you're thinking hormones, right? Your glands, your hormones, all those structures that relate to the endocrine system. And when you look at your coding manual in terms of how the endocrine system section is set up, you'll notice that it's by each of those body parts that make up the endocrine section, and those different procedures for those. And then your nervous system, of course, is dealing with your brain, your spinal cord, and your nerves. Okay, and so in that particular section, you will see they have your procedures on your nervous system, and then you got a section for procedures on your spine and your spinal cord, and your procedures on your nerves, procedures on your nerves, procedures on your spinal cord, and procedures on your brain. That's how that's broke down. And what you're going to notice in that particular section is that some of the things that they, some of those procedures that they perform on the spinal cord, you'll also see them performing in the brain area. So it's just in different parts, but they'll be similar type procedures. So you have to pay attention. Are they working on the spine, or are they actually in the brain? Okay, so let's look at the first case that we have, and I'm gonna have you to read it, and if you're having trouble, you can go ahead, and the way we did last time, you go ahead and read it. Once you finish reading it, just put your initials in the box, in the chat box, so I will know about how many people are done. If you're done before everybody else, go ahead and start seeing if you can attempt to look it up and find the code. And somewhere in between there, we'll talk about some of the things that affect the coding for this particular context. Okay, so let's Go ahead and read and then attempt. We're going to attempt the code. All right, we see somebody got something. Let's see. Okay, let's see. All right, so Sharon looks like she says 61519. How did you look that up, Sharon? So what? Okay, so really, what we have here is this is skull-based surgery. This is what they say, skull-based surgery. And what you need to know about that is um, there are actually 3 stages to this procedure. So when you're looking at skull-based surgery, 3 stages. They're going to have the approach, you have the definitive procedure, and then repair and reconstruction. Now, when you're looking at this type of procedure, you may not always have a repair being performed, but there are 3 stages. What you also need to know about that is a lot of times you're going to see multiple physicians or surgeons who may do the procedure. So, for instance, you may have one that would do the approach and another that may do the definitive procedure, and then another who does the repairs. So, and these surgeons could be from different specialties. You know, you can have a neurosurgeon, an ear, nose, throat doctor, a plastic surgeon, or so forth. So there are 3 components, and like I mentioned before, you may or may not have repair. You have to read the context of your problem. So with that being said, we know that for each of those, there are different sections of coding for it. I'm not sure, Sharon, how you look that up, but the way you would look that up in your index is go to skull-based surgery. Okay? So you got approach. Your code for your approach procedure will be differentiated by your anatomical area that's being accessed. So that's what we mean by approach. How you get in there? So for example, craniofossa, middle craniofossa, posterior craniofossa, the brainstem, or the upper spinal cord. These are different approaches. What an anatomical area is being accessed for the approach. Felicia is correct with the approach. Please tell us how you came about. Give us how you got there. So what did you look up in your index? You went to what? Skull-based surgery, then what? You went to skull-based surgery. Okay. Middle craniofacial. And what was our approach in this problem? Infratemporal. Right. And who did the approach? And who we coding the approach for? Yeah, that's right. That's the ENT, the otolaryngologist. That's the ear, nose, throat doctor. He did the approach, which was infratemporal. Okay, very good. So our code there, so that was a little bit of mid-term, right? Otolaryngologist. So our code for the otolaryngologist or the ENT would be the 61, what do we say, 61590. But the code that's correct is listed under middle. Let me see. Let me look at what you're looking at. So we went to skull. Let me move back. Let's see what you're saying. Skull base surgery. And you're saying it was, but the correct code, that is correct, is listed under not the base. Okay, so when you go where, that's not, so under skull base surgery, all you have is middle cranial fossa. I don't see a base of the middle cranial fossa in the index. Oh, you talking about when you go back and check it in the tabular? Okay, so your three, now think about, so what you have is you have three stages, okay? Approach, definitive procedure, and repair reconstruction. We are coding for the approach, not the definitive procedure. That's our second code. So it's three stages. So the approach deals with how you're accessing the area, okay? So that, for example, your craniofacial, middle craniofacial, that's the way we're getting there. Now, the definitive procedure code pretty much describes the surgical intervention being used for the surgery. Okay, so that's when we're going to need the definitive procedure. So which is what we need now. So 61590, we will find that going to skull base surgery, middle craniofacial, then infratemporal approach, and that's for our ENT doctor, the otolaryngologist. Now we need to code the definitive procedure. Not 61650. So how we're going? We still go to skull base surgery. All right, and we're going to still have middle cranial fossa. And let's see what you all guys are picking here. All right, so you're saying 61605. Let me see what that says. 61. So let's see, resection or excision of neoplastic vascular infectious lesion of infratemporal fossa, peripharyngeal space, petrous apex, extradural. Right, and that's what we have, extradural. Let's see. Okay, wait a minute now. All right, so wait, it says peripharyngeal space. I think we should be 61607, correct. I was just looking. It's midline skull base extradural. You see that in the second sentence? Let me see how it looks. Yep, midline is what we need. See the second sentence of our case. Everybody see that? It's 61607. You can compare 61605 and 61607 and see how they're different. Everybody see that? Yes, you gotta pay attention. I had to slow down. You have to make sure you're reading, because if you go too fast, you make a mistake. Okay, so in this case, do we have any repairs going on? Because that's the third stage. That's right. There's no repairs. And that's what I was just mentioning to you, is that you won't always, even though it's 3 stages, possible stages, you're gonna see the approach and the definitive procedure, but you may or may not have um, a repair. Your repair, now see, your definitive procedures could be by biopsies, repair, resection, or excision. So the repair we're talking about is the stage 3, are more extensive type repairs, like some type of graft or some type of pedicle flap. Those would be, or cranioplasty. Those are extensive type repairs, but again, you will not always have an extensive repair in this type of procedure. Now, Tracy mentioned modifiers. So you're not going to need any modifiers for this particular example. You may be looking at or eyeballing, say, modifier 62, which is for co-surgery, or modifier 51, which is multiple procedures, or modifier 66, which is team surgery. You're not going to use any modifiers in this particular case. This procedure is common for multiple surgeons, which is already inclusive, and most of the time you're going to have them doing separate stages of the procedure. Now, when you may use a modifier is if you had one surgeon who does both the approach and the definitive procedure, then you can use modifier 51 in that case, but that's not what we had here. We had the neurosurgeon doing the definitive procedure, and we had the ENT doctor doing the approach. That makes sense. Okay. Any questions? Any more questions on that one? Well, no, right, correct. You won't use it with the, 2 surgeons. Only if one is doing multiple phases, then you can possibly use your modifier 51, which is for your multiple procedures. All right, let's move on to case 2. All right, I'm gonna give you a minute to read it and just initial the box when you're done, and just move on to trying to code it, and we'll talk about it a little bit. Ooh, Amanda, you quit. I don't think I can read as fast as you. Yeah. Once you read, see if you try to attempt to look it up. Anybody got any ideas? going to jump in just a second. All right, let's see. Let's see if I can help you out. Okay, for case 2, that's a good question, Katrina. So what we're going to do here, so what this is like a spinal block. This is what this is about. This is a spinal block, which is, they use that to block the pain receptors in the nerves, okay? And so the way they are approaching this is through an injection into the epidural space. You're close, Sharon. That's not correct, though. You're getting in the ballpark. So they are injecting into the epidural space. Now, Katrina asked about the fluoroscopy, which is a good call. That's going to be dependent on whether it's included in your coding, your code for the injection, the epidural injection, which I'm going to tell you is not once you find the correct code. So yes, a direct answer to Katrina's question is that we are going to have to capture the fluoroscopy. And what do we use the fluoroscopy for in this case? Were we doing a diagnostic procedure? What are we doing with that? We're using it for guidance. All right? We're using it for guidance. Fluoroscopy was used to identify the L3, lumbar 3, lumbar 4 interspace. So we're using it for guidance for what we're trying to do, which is a pain block. This is what this is. Now, so what we're going to need is to code for that epidural injection, and then we're going to need to code for our fluoroscopic guidance. Now, if I wasn't here saying that, you would have been able to determine if that was needed once you looked up your code for this particular procedure, and that will allow you to know, it will tell you if it's included or not. All right? All right, so somebody has 62350. Now, tell me how you're looking that up. What are you going to? How are you looking at? All right, you went to epidural, then what? Okay, and so somebody, man, you went to guidance and injection. You tell me what you find? I went through epidural. And look it up again. Go through epidural. Well, you could try to see if you can find it somewhere else, but I found it on the epidural. And we can find it in multiple ways. All right. Now, 77003 would be for the fluoroscopy. How did you get there? So we got two things going on. We're trying to look up the actual procedure code and then the radiology code. Let me know if you're getting confused, because we got several things happening. And your notes are going by fast, so you may have to type it again if I didn't respond to it. So 77003 would be our code for the fluoroscopy. And did somebody say how they got there? Because if not, I can tell you how I got to it. Okay, and then somebody gave us 623. Tracy, you are extremely close. 62310 is extremely. Let's see, 62. Let me see what that says. 62311 is actually the correct code. Right, because 62310 is the parent code, right? So injections of diagnostic or therapeutic substances, including anesthetic, spasmodic, opioid, steroid, or other solution not including neurolytic substances, including needle or catheter placement, includes contrast for localization when performed, epidural or subarachnoid, I can't even say that, but 62310 is cervical or thoracic, but we need what, lumbar, so that's 62311. Now, it said, now the way you get that, I went to epidural injection to get the 62311. And somebody may have said that, but your comments was going by so fast. But 62311, I went to epidural injection, and then in order to get the fluoroscopic guidance, I went to fluoroscopy, guidance, catheterization, spine. Or you could have went to radiology, radiologic guidance, fluoroscopy. A lot of times if you need to code for your guidance and not sure where you need to go, try radiology. Is like a overall arching umbrella for all of them. You can probably find it there unless you know something a little more specific. But fluoroscopy was pretty easy. Now, what you would need to apply to your radiology code, which is the 77003, right? You need to apply a modifier, and so usually with your radiology, you have the common modifiers is a TC for technical component, or modifier 26 for the professional component. So here you're going to need modifier 26. And so the way you look at this, you use a modifier TC, which is technical component, when you are a facility coder, and what you're trying to capture is the use of the equipment. You use modifier 26 if you are the actual physician performing it in the facility. They are, your HIT211 or CPT can be used interchangeably as needed. You can use both of them on CPT codes or HIT211 codes. Sometimes there may be some that are, but they may be based on who you are reporting to, what insurance companies you're reporting to. But right here, we just educationally speaking, but with your TC and your 26 modifier, that's a pretty standard modifiers to use with radiology codes, because you got the physician professional portion in which they like if they're interpreting it, are they performing it, and then you also have the technical component dealing if you have somebody else who runs the test, or like here using the equipment. You see what I'm saying? They talk about the TC and 26 modifier in your chapter 25 of your radiology, but that's what it is. TC for technical component, 26 for the professional or physician part. And so your radiology codes, a lot of times you will see it being in, what do you mean either one will work? In this case, you need modifier 26 because this is the physician. This was not someone else performing it. The physician did it while doing the pain block with the epidural injection. Now, if like a lot of times, say for example, with X-rays or something, your doctor refers you to a some ancillary location or some kind of place, a lab place, a radiology place to get a particular X-ray or something done, right? So they don't do it in-house. They send you out, and then they send the report back. They send the results back to the physician, who then does their interpretation. They look over, they interpret it, create their report. So if in that case, then you would do like your 77003, and if it's the physician doing his part, it will be 26. But if you going to report for the radiology place where you were outsourced to, then they would report the same code, but they will put modifier TC. Now, if you notice, you asked about the catheter placement. So when we were reading our code, which was 6.2, let's see. Well, let me go to it. All right. If you go to your radiology chapter, it will talk about it even more, because those two are very common for your radiology type codes. Okay. Now, if you looked at your code for your 623, so Mark had asked about the catheter placement. That's included in your 62311 code. If you remember when I read it out, it includes needle or catheter placement, includes contrast for localization when performed. So we did, we coded for the guidance, but we didn't code for the contrast. You see what I'm saying, Mark? So if you go back and look at your 62311, you will see catheter placement was included. Now, with these type of injections, hold on, because I think it's something else I wanted to say. So this was one single injection for this case. Can you see that? Okay. So we talked about one single injection. Now you can have situations where they have multiple injections. Oh, you got your wrong glasses. I'm so sorry. I left mine one time before. I got mine. I know how that is when you can't see. I don't even see my glasses. For some reason, I don't have my glasses on tonight, but I'm doing pretty good. Let's see if I can make it larger for you. Hold on. I might can do it, give you a little something better. Can you see that a little better? But see, the problem is it don't all fit. Oh, in your book, okay. I thought you were seeing on the screen. Well, do the best you can. I'm going to talk to you most of it. So here in our case, we just had one injection. Now, you could have a situation in which you have multiple injections, but say they use just one needle and they just manipulate that one needle for the multiple injections. If that occurs, then you're going to report only one code. Now, if they move the needle and reposition it for another injection, and then you can code twice. So that's another situation. So when you're coding in this section, you need to be paying attention to what's the purpose of the injection, what's the approach. In our case, we had an epidural approach, but as we were reading, you saw that you can also have a subarachnoid approach, and then you need to know your site, like cervical, lumbar, and the substance that is injected. But in our case, for our code, the contrast material was included in the code. Everybody's blind in this class, I guess. All right. So, everybody, any questions on that one? Yep, there is. There are multiple. All right, we're going to move on to the next case unless, why can we use 622? Let's see. Give me a minute. All right, 62281. All right, so let's see where we. All right. Now, so this is for, so we gonna hold on a minute. You said 62282. Okay, 622. I'm not in the right place. No one that wasn't making sense. Hold on, 622. All right, so that is injection infusion. Example, alcohol, phenol. Okay, that's that. It's not of neurolytic substance. So that's not. We're not using a neurolytic substance. And then in code 62310, it includes our needle, our catheter placement, and our contrast. And then in this other one is of neurolytic substances, but that's not what we are. We're using lidocaine for our placement of the catheter. It's similar, but this one is not including the neurolytic substances, but includes the catheter placement. Because see, if you use the other code, it doesn't have the catheter placement, but it's saying of neurolytic substances like alcohol, phenol, isosaline solution, and that's not what we have. We have infused with lidocaine, and we also have catheter placement. So, right, exactly. You have to read. You have to make sure you read everything. Reading real fast will get you in trouble. Yes, that as well. And see, and then the one you listed, it says injection infusion of neurolytic substances, and the code that we need is injection of diagnostic of therapeutic substances, including, and it lists those out, and not including neurolytic substances, and it also includes catheter placement. So that's the major difference. So they both said injection of a substance, but the 62282 is injection of a neurolytic substance, and then also the catheter placement. You see that? That's the two differences in those codes, which makes a big difference. What are you injecting, and also the catheter placement. Now, sometimes when you're looking at your codes, you see that if you don't know what they are referring to, then by all means use your Googler. I like to call it a Googler. Or if you have kept, if you got your AMP text and stuff like that, coders should keep those types of reference materials so that you can have clarity. Maybe you don't know what, even if you're looking at it and comparing to see if I need this code or that code, if you don't know what something means, just look it up. That's all. And the more you do that kind of thing, your medical terminology and your vocabulary in this area will just continue to grow. So always stop and look it up. That's going to help you. Yes. Okay. Now, let's. So we covered that pretty good. Let's go on. And we're going to move to case 3. Moving right along. Okay, let me close this one down a little bit. It's a big doozy. I'm going to give you a little. Okay, hold on, let me get it all the way in the screen. Can y'all see that? I done made it too small, probably. All right, go ahead and read and initial like we usually do. All right, I'm gonna help you out in just a second. Yeah. All right, let's see. How many people read? Okay. All right, let's see what we have. Case 3. It's a lot to read there. Okay. Now, so basically what you are looking at here, this is a spinal decompression. Okay? Spinal decompression. Um, and so you gotta look at a couple of things with the spinal. So let me tell you how we're gonna approach this. I'm reading it from here. So with a decompression procedure, you got to look at if you look down toward the middle bottom. There are several things, and also the operation. Your diagnosis will give you some idea of what's going on. So we know they got a cervical disc herniation in the C6, C7. So that's in the cervical area. Now, one thing you can look at the operation. That's the overall procedures that went on, and then you look in the body of that paragraph. It's going to give you descriptors to help you determine what else needs to be added. So right off the top, I see a discectomy. Right? Do you see the discectomy? Yeah. So and then if you look down in, it tells you that. Let's see what sentence that is. Look at. Okay, right here say at the end of the procedure, the C6, C7 nerve roots were palpated and were well decompressed. So that's what we got going on here. They were decompressing that area of the spine. Now they're trying to relieve that area. So that is kind of the focus. So I would start now, and what they did was, in order to help do that, they did a discectomy. So I would try, if I were you, to go. I would start with maybe doing um, a, a decompression, or go to discectomy to see what I can come up with. That's just a start, okay? Because you need to look at that. So we're looking at what type of procedure did they perform and what was the goal here, right? So they were trying to decompress that area. So that's what that was. And then you're gonna pay attention to what approach and what technique did they use, and what type of procedure was performed for the decompression. The discectomy was performed. Right? So when you find your codes, you have to look them up. So what we have, Sharon said 222 20. You are getting somewhere close, I would say. Now, if you realize we are in endocrine and nervous system, and so what would you think our codes would start with? 6. All right, so I'm throwing that out there, but when you look that up, so say if you go ahead and go to, why don't you try going to discectomy and see if what you can find. Go to discectomy, and where did someone already say go there and see? All right, so Tracy said 6'3". Did you I think you might be to flip your numbers. Did you do a transpose? Do you mean 63075? Yes, I figured. That's what I was hoping you would say. So when you look that up and you went to 63075, right? And so we look that up. I'm going to look it up. Go to that. So I'm going to take you somewhere. We're going to go on a little ride. So we're going to go to 63. Everybody flip there. Yeah, under this, if you went to discectomy, you would have went to cervical. Did you not see anything on the cervical? There should be some there. So 630, still flipping them. I'm slow. Sorry. Alright, I think I'm out there. 63075. So it says discectomy anterior with decompression of spinal cord and our nerve roots, including osteophytectomy, cervical, single interspace. So that looks pretty cool. However, there is a however. When you look at the notes right up on the 63075, okay, it says do not report 63075 in conjunction with 22554, even if performed by separate individuals. To report anterior cervical discectomy and antibody fusion at the same level during the same session, use 22551. So what is 22554 and 22551? So let's flip. Now somebody posted some codes in the 22 arena, and I'm well aware of that, but I want to point something out here. Just follow me. So 22 what was the code? They listed 22554. And it says 22554 says arthrodesis anterior antibody technique, including minimal discectomy to prepare inner space other than for decompression. And it says cervical below C2. So we are below C2, but this is talking about arthrodesis, which is pretty much talking about a fusion. That is occurring between the interspaces. So like we're talking about in our code, we have what are we in? C6 to C7, which we do have a fusion, right? So if we went back to that 63075 code, it says we cannot report the 63075 and the 2254 together. So arthrodesis is nothing other than the infusion portion. But it says if we're going to report the anterior cervical discectomy, which we have, and we have an antibody fusion, if we're reporting them at the same level during the same session, we're going to use 22551. Right. So what it says in the note says do not report 63075 in conjunction with 22554, even if performed by separate individuals. To report anterior cervical discectomy and antibody fusion at the same level during the same session, use 22551. So I just read to you 22554 because I was asking you, well, what is that code? So if you saw that in the notation, I would go and look at it. So that's an arthrodesis, which is referring to a fusion. If we're looking at our case, we do have a fusion, but it just told us that we could not use the 63075 and the 22554 together. However, if we are performing both at the same level, at the same session, are we at the same level? Right? It's just C6 to C7, right? So we're going to use the 22551. That's going to be our first code. So that handled our fusion and our discectomy. All right, let's see what this 22. Let me go to 22551 says arthrodesis anterior antibody, including disc space preparation, discectomy, osteophytectomy, and decompression of spinal cord and on nerve roots, cervical below C2. So that covers discectomy, decompression, and fusion, right? So if we're looking up, what do we have in our operation? And see that microdissection, microdiscectomy, that's all a discectomy. And then that fusion, that removal of the spur is included. So the fusion is also included because when we looked up the discectomy or the decompression, right, it said that go to the what code we reporting, the 22551, which will include both, right? So we've taken care of all of that. Do you see that? So that one code, that 22551, has taken care of the discectomy, decompression, and the fusion. But we had to pay attention to that note, right? Now, the other thing we need to pay attention to, so this would be in reference to your guideline. I got my hand in 50 pages. Let me move it out of my coding manual. I need some, what you call bookmarks. I might have to look it back up. So when you try to code for spinal decompression, right? So we took care of the discectomy and the decompression. Now you also need to pay attention to whether you if they are using some type of instruments in order to perform the decompression. So spinal cord. So we got the decompression, discectomy. We need to pay attention to instrumentation. Was any instruments used in our case? So no, Sharon, we will not need the 63075 because when we looked at our notation on the 63075, we it said to use the 22551, which will include the decompression and the fusion. Remember? So now 63075 is out. We're using 22551. But when you're doing spinal decompression coding, we also need to see if they use instrumentation. So what do we mean by like any kind of devices, implants, plates, rod screws, hooks? Okay, so do we use any instrumentation? All right, so we do need to have a code representative of the instrumentation. This is all a part of coding spinal decompression. So the way we would code that, you can go where I went to. How would you look it up? Let me ask you. How would you look up? We're doing a spinal decompression, and we did use instrumentation. Okay, so what I would go to is spine insertion instrumentation. But it was several things because they use screws. It was several, but you only need one code. Look at it, see what you get. Okay, so you close, Amanda. You're very close. That's close. You're still not there. Yes, it is. It's an add-on. Let me see what you got. Let's see. All right. So you chose 2-2. So you went to spine, insertion, instrumentation. All right, so 2-2. All right, so 22841 is internal spinal fixation. Let me see what else y'all put. 22840. 22. All right, somebody has it. 22. Did I see the right code? So what you should have is an interior instrumentation. That's 22845. Interior instrumentation, 2 to 3 vertebral segments. And how do we know it's anterior instrumentation? What did I? Right, so some of this other, I see you have mentioned 22842, that's posterior. Yes, it's anterior is what we need, which would make it the 22845. And it's 2 to 3 vertebral segments. Is that what we have? All right. Now, the reason why we know to code for this, because when we are doing spinal depression coding, we need to keep in mind that we're looking at the type of procedures performed, what was the goal of this, which was a decompression. We knew we had a discectomy and a decompression. We also need to know about the fusion. Did we have a fusion? Remember, that was a part of this. If a fusion was performed, how many inner spaces were fused? Because you remember in that notation, it asked us, was it on the same level, right? So we need to know that, because that will make a difference in our code. We also needed to know about the instrumentation. Did we use any instrumentation in the spinal decompression procedure? If that is the case, then we went to spine. What did I say? Spine. I can't remember what I went to now. Y'all remember? It's on recording. I went to, let's see, spine insertion instrumentation. Right now, another thing we need to look at if we're doing spinal decompression coding. Did we use any bone grafts? That's also important because that means another code. Yes, it would, Sharon. You're so smart. Yes, that is a bone graft. So how do you think we're going to look that up? Okay, I think that's good. Let's try bone graft. That makes sense. At least to me, it makes sense. What do y'all think? Any takers? What do you think? All right, so let's see. You said 63051. So let's see. We need no, we're not. It's not 63051. It's not gonna be that. So you went to bone graft. What did you do after you went to bone graft? What did you choose? what did you do once you went to bone graft? So you went to bone graft. Oh, let me look. Okay. Bone graft. And you went to cervical. Oh, I see. Okay. So you need to go, let's see, bone graft, spine surgery. Bone graft, spine surgery. And somebody has 20930, very close. Very close. Read that again. Let me see what that 63051 says. All right, 20931 would be correct. 20931. See, that 63051 is a lamинoplasty, cervical with decompression, two or more vertebral segments. Now, the 20931, which we went to bone graft spine surgery, 20931 says, let me flip over. Yes, it's on the graphs. Let's see, 209. Okay, this says allograft structural for spine surgery only. So it used allograft. Does somebody know what that means? Graft from the same species, right? So they're using an allograft, and if we read in the in our case, it said where is it? Let's look down. Okay, so the bone plug was taken and its central canal was filled with DBX bone putty and was impacted into position. So, but they did not talk about removing a bone plug from the individual themselves, right? So it just said fusion with bone plug, but they did not graft the bone from that person's bone. They had the bone plug and they placed it into this patient, right, which would make it a allograft, and they use that. So they're just augmenting that patient's bone. So they're using that graft to do that, and so they will fuse it, and that's exactly what happened here. They fused it with the bone plug, and it talked about putting the bone putty in the lateral girders. That's something is common to this grafting situation. When they graft the bone plug, and they'll fuse it. Even sometimes with a guttural fusion as well. But so the thing we're looking at here, because if you're looking in that section when it's talking about the grafts, you'll see it mentions a structural graft, a morphalized graft, an allograft, autograft in those sectional codes. And so basically, if it's saying it's a structural graft, it's talking about like a larger piece of bone versus a morselized graft. You think about a morsel of food, it's like fragments, small bone fragments. That's what they mean by that. And so we just talked about what allograft mean versus an autograft, meaning coming from the person's own body. So, but those are some of the terminology that you see in that section of codes. You see those there in 20930, because 20930 said allograft mortalized versus 20931 said allograft structural. Right, and those are add-on codes. So these are all added on to our main decompression, spinal decompression code. Now, you just keep in mind all the things that were important if you're coding for a spinal decompression. So this is something you just need to read over. I'm pretty sure you'll probably have to go back over that, what we just did, but just realize we did look at what was the actual procedure that was being performed, which is that spinal decompression, and they utilize a discectomy, right? And then we also made sure you paid attention to the coding notation, and we needed to know about whether there was a fusion present, and was it at the same session and at the same interspaces along the spine, right? That was important. Any devices, instruments were being used, because then we had a code reflecting that. And finally, we were interested in graphs, right? Well, did we have any graphs? And we talked about some of the terminology using that. Now, it did. Let me see. See if we need to cover that. Hold on, let me look at this. Let's see. So the okay, let's see. Okay, so what I was going to tell you about, didn't somebody mention the microscope earlier, right? I think we had mentioned the microscope. Okay, so let's talk about that. So many components, I got to make sure I'm not missing stuff. Okay, so it did talk about a microscope, so we do need to be concerned about that, because a portion of when you're doing your spinal decompression coding, you're going to determine whether a microscope is being used to perform some type of micro dissection. And we did have a micro dissection, right? So now if we were to code the operating microscope, so if you were to try to go to that code, let's see, how would you look that up? You're going to look up micro dissect. Excuse me. So what do you come up with if you go there? No, this is going to be a 6 code out of our, this is going to be right out of our, the section we're working in, which, all right, how did you find 6? That's the correct code. How did you find that code? So you went to operating microscope. Everybody saw that? She went to operating microscope. Now, let's read our notation. Alright, so if you go to that code, so you're going to check that in your tablet, right? And it's an add-on code, 69990. It says microsurgical techniques requiring use of operating microscope list separately in addition to code for a primary procedure. Now, if we go up right above it and look at the notation, right, it says the surgical microscope is employed when the surgical services are performed using the techniques of microsurgery. Code 69990 should be reported without modifier 51 appended in addition to the code for the primary procedure performed. Do not use 69990 for visualization with magnifying loops or corrected vision. Do not report 69990 in addition to procedures where use of the operating microscope is an inclusive component. And then it lists codes in which the operating microscope is inclusive. Is our code that we use in that list? So do we need to code the operating microscope? Yes, that's correct. Did everybody follow? So, so you would have attempted to code it, but see, and that's a good lesson and example again in reading your notes around your code. Don't just grab the code and run. See, if you didn't read that, you would have flew past it. You would have added it. Just a nice lesson. Okay. Have we thoroughly discussed that? Any other questions? So now you have some idea. You probably need to practice a little bit on what we're looking for when you find out you're coding for a spinal decompression. All right, let's move on. Case 4. Yes, which you can't. That would be rejected. You trying to yes, you are unbundling, so that is already included. It's inclusive. All right, let's read case 4. This initial and then try to code. Let's see what we got. Alright, so Sharon is saying 67840. That is not going to be correct, but I do understand why you chose that. I'm going to tell you. Does anybody know why 67840 is not going to be the right thing? Just let me see where everybody. Can you hear me? Okay, it lost connection. Something kind of crazy just happened. I was talking and then it just went gray. I said, oh my goodness, that hasn't happened. But we're back on, so we're not going to worry. I don't, let me make sure it's recording. Let me make sure I don't want to keep. Okay, it's still recording. All right. Okay. Now, what was I getting ready to say? Okay, here we go. Now, Sharon had said 67840 because now we're in eye and ear. So we just moved over. We're in the eye, and so this is an eye type of problem. So it would stand to we would stand to believe that we should be in the sixth area. That will make sense. However, what we have to pay attention to, and this will happen in quite a few of when we're in like musculoskeletal or different sections. The difference between when we're dealing with skin, a procedure on the skin versus a procedure, say in musculoskeletal or in ear or eye or something of that nature. Okay, so in this problem, let me ask you a question. In this problem, so we have a nevus, which is, do y'all know what a nevus is? Yes. So they have a nevus on the lower eyelid. Now, where did the doctor remove it? That's what you need to do. Look it up. So where did we remove it? From the dermis. Okay. Because it's moved from the dermis, what is the dermis? What is that? What's another general? Skin. All right. So because it's being removed from the skin, that means that we need to go to a. So I went to excision lesion. Right. 11441. And I went to excision lesion skin benign or excision skin lesion benign. Again, if so, the difference between, you always need to pay attention to what's the depth of the procedure. This was like a little tricky one because we were actually supposed to be coding from sixes for the eye and whereas we are nervous and endocrine. So you already kind of figure what your code should start with, but you also need to pay attention to where the procedure is actually being performed. So if it's very superficial layers of the skin, then you need to code to the skin. And so a lot of different procedures, it may list out your muscle or your bone or something like that. Then you could code actually into those particular sections like your musculoskeletal versus the skin. Okay. Um, so in this particular case, it was a full thickness incision into the dermis, which is the skin, which will have moved us to the integumentary um, system, right? Um, so if we have an incision or incision or procedure that is involving only the skin of the eyelid, then we're going to code from our integumentary section. Now, if the procedure involves the lid margin, the margin of the lid, which is basically like that area where your eyelashes is, that where the little wet part where your lashes are, or say the tarsus, which are like connective tissue that helps to form and support the eyelids. If it goes into those deeper levels, then we will code the removal of the nervus from the eye codes. So does everybody understand? Always pay attention, no matter what surgery section we're in, that can happen. You need to make sure, are we in the skin, which is a superficial level, or are we going to something deeper? Very good to pay attention to. All right, let's move on to another one. We're starting to get late. So like we did before, we're going to keep going, and then when we run out of time, you can work on some of the cases, because I have 12 each time. If you have questions about those when you work through them, make sure you send me an email if we don't get to all of them. I try to do as many as I can. That's what we did last time. I didn't get any questions, so I'm not sure if everybody finished up the ones we missed last week, but you can send for that one as well if you like. Okay, so this is case 5. Read it and initial when you are ready. Okay, so Tracy says she wants to go. So we got two different 67105 and a 67113. You are close, but that's not correct. Let's take another look. Tracy actually may be a little closer than Sharon. Look back at that one more time. Alright, 67108, Tracy, is correct. How did you look that up? What did you go to? I went to cryotherapy, retinal detachment, repair our retina. No, cryotherapy, retinal detachment repair. Then the other way was retina repair, detachment, cryotherapy. Oh, I see what you did, but did y'all see how I looked it up in the index? Right, so we have a retinal detachment, right? So basically, the retina comes apart from the choroid. It could be a partial or total retinal detachment. Um, and we chose the 67108, and it did include the vitrectomy, right? Because it used a vitreous cutter. So all that was included. So we didn't need but one code. Everybody see that? 67108. Okay. All right. Let's go to case 6. Take a look at that. See if you can look that one up. What, Miss Katrina, you lost something? What happened? You still hit me? Oh, I didn't realize. I didn't see it. I hope it recorded. You hear me now, right? I don't know what's going on tonight. Sorry about that, you guys. I'm not sure what the problem is. When you go back and listen to the recording, if there's a section missing and you need to know what it is, just let me know. And I can tell you. Hopefully that's not the case. Anybody? K6? Okay. No problemo. Okay, so you say, okay, so what, okay, where are you trying to look? How, where are you looking up, Miss Sharon? Let's start there. And I'll start from there. So basically, we got a cancer here, right? You went to skin. Okay. Now, notice here it says a full thickness excision of the lid margin and tarsus was performed. So would that still be skin? You remember in the other question where we went to skin, what did I mention? See, the other one talked about is incision of the dermis. This is excision of the lid margin and tarsus. I actually mentioned what tarsus was. You probably forgot. But that's the connective tissue that that helps to form and support the eyelids, right? And we talked about the tarsus and the lash line, right? And remember, I said when we, if those things are what the procedure is being performed on, then we can code from our eye code. So what we just essentially have done is I came down and now we're back on the eyelid, but this time it's not the skin, right? So they had cancer on the eyelid, left lower eyelid. Excision was performed on the lid margin and the tarsus. Then they had some reconstruction. So what do you think will be our key term to look up in our index? All right, you can go. Let's look up eyelid, see what you come up with. We can try that. Okay, so Katrina says 67850. You are somewhere in there. Where did you go? So you went to eyelid. How did you look that up? I'm gonna tell you guys where I went to repair because we have a reconstruction. You can look up reconstruction. I went to repair. A reconstruction is a repair. Sometimes you use synonyms. What's another word? I think it was another word I also looked up. All right, you can try excision. See, let's see what you come up with. Try a different way. All right, someone said 67966, and I do like that. How did you get that, Sharon? Let me see what it says. I got mine. I went to repair eyelid excisional. How did you go? And 6-7. Okay. 6-7-9. All right. 6-7-9-6-6 says excision and repair of eyelid involving lid margin, tarsus, conjunctiva, canthus, or full thickness may include preparation for skin graft or pedicle flap with adjacent tissue transfer or rearrangement. And we have 67966 is over 1/4 lid, over 1/4 of lid margin, which is what we had, because 67961 says up to 1/4. So 67966 is our code. Now there is a modifier that we should add to this code. What do you think? Okay, not quite. That's good, but it's something even that you can be more specific. No, look at it. So you got left, right. It's still in that. Yeah, we finna. I'm gonna have one other. I'm gonna do out of radiology, and we're gonna wrap up and talk about the cases. We're gonna jump because it's getting late. We're gonna close it out. E2. What is E2? Lower left eyelid, right? So that's what we need there. Okay. Now we're gonna do one out the radiology, and then we're gonna cover the cases. And the other 2 or 3, we didn't have that. I don't think we had that much left because it is getting late. I always put 12, even though I know we can't do them all. But sometimes if you go faster, I don't want to run out either. So, and you can always practice. These are extra practice ones. Let's go to case 8, and then we'll look at our cases for the week. All right, this is a short one. Read that, and then we're going to wrap up. So this is a radiology. And so what's the radiology procedure being done? Let me help you guys out. All right, let's see. So where are we gonna go? You want to do injection, or you want to go to radiology? Oh no, this is a physician injecting dye into the cervical spine. So that's not a radiology. So we're gonna go to injection. Let's see. Oh, did you already look? Let's see. Okay. everybody's getting tired. Oh, still flipping. Give me a minute. Injection. I'm going to where you at. Let's see. Okay. Okay, let's see. I do see injection, spinal cord. All right, let me try something else. All right, Sharon has 62310. How did you look that up? You went the injection and what? Okay, you're somewhere in the neighborhood. Let me tell you what I went to. Go to discography, and then go to injection. Discography, injection. All right. Tell me what you get. What do you think? What you got? Now that's 722. That's for your that's your code for your the radiology part. So you the 72285 is the 72285 is the radiological portion. 62291. Yes. All right. So those are the two codes we need. Let me read that out. So we went to discography, injection, and 62291 says, I'm getting slower and slower here, you guys. 62291. Okay, injection procedure for discography, each level, cervical or thoracic, right? And we in cervical. All right, and so then our radiology was the 72285 portion. All right, I'm getting to it. Almost there, guys. 722. I've lost somebody already. Probably got to go to work tomorrow. 72285 is discography, cervical or thoracic radiological supervision and interpretation. So that's the radiology portion. Now, it says, so for the physician code, right? So for our physician code, they're gonna code 62291, and then they're gonna code 72285, and we're gonna use modifier what? What's the modifier for the physician? 26. There you go. Now for your for the facility, okay, because we have it was performed hospital outpatient center but the physician does not own the equipment, that means the facility owns the equipment. So the facility would code the same code, the radiology code, the 72285, but we're gonna use what modifier? TC. There you go. Because that's the code to reimburse on the equipment usage. And only the physician will code the actual procedure, the 62291, and then the 72285 modifier 26. You understand how that works? Yes. Always ask yourself about, is there a modifier applicable to whatever you're coding? You always need to ask that question. All right. So we're going to wrap up there. So we had like a couple. We got a lot of them done. We did not do case 8. No, 7. We didn't do 7. So you can look at that on your own. Again, you can send me a question on it. We didn't do case 9 through 12. I think we're running about 6 per night. But I purposely over. So just practice, and again, shoot me an email. And I'll put it in for those who are not in my class. I go ahead and pop my email down here again. Yeah, so it's fine. So the others you just do on your own time, and you can still send questions. Okay, let's look at our cases for this week. Let's see what we got. And then I'm going to let you go because I don't want to stay in to 12. I know I have to go to work tomorrow. Alright, so I have 3 cases for week 6. Case 1, you gotta have 2 codes, first of all. So you're gonna need the code, your procedure code, right? So you know how you find your procedure. So that one is easy. But your second code is gonna be a HIT211 code, which is probably why you probably didn't come up with case 1. You need a HIT211 code, and you know your HIT211 covers things like materials, supplies, durable medical equipment, stuff like that. Okay, so you're gonna code for the procedure, but then there is also some type of equipment or something that's being provided in that context of the case 1. Did you see that when you were working? I think Sharon said she started the cases. If you started, you would have noticed there in the description they gave the patient something, which is what you're gonna capture in your HIT211 code. Now you don't have a HIT211 manual, but your HIT211 codes are in Doc Sharon, just in case you didn't realize that. So that's where you get your code. So that's case 1. You need 2 codes, your procedure code and your HIT211 code. Yes. So see what you can do with that. Okay. So in the second case, you got in the second case, you're going to use a E&M code and a HIT211 code. So again, there is a device that's being used in case 2. And so you're going to have your E&M, that's way back, week 2. E&M, you're going to need to utilize your E&M. And then the HIT211 code is for the device, or the machine that was given to the patient. Yes. Alright. And you know your HIT211 code are a letter and 4 digits, right? Alright, so that's case 2. Everybody got that? Case 3, same deal. You got an E&M code and a HIT211 code. And they did something for the patient. They utilized something, and you need to capture that in terms of your HIT211 code. Again, so your HIT211 is like your DME, devices, supplies, materials. That's what HIT211 a lot of times cover. So all three cases, you needed two codes. The first case had a procedure code, and then and all three of them had a HIT211 code as your second code. So your first case needed a procedure, and then a HIT211, and then your last two cases used E&M codes, and then a HIT211. I cut out again. Oh my gosh. So case 2 and 3, you need an E&M code as your first code and a HIT211 code as your second. Okay. All three cases, two codes are required, and your last second code will be a HIT211 code for all three. All right. All right. We are almost 11:30 on the dot. I'm done. Unless you have any questions. Is there a replacement code? Okay, you're asking case 2.